Today's topic that I chose is prolapsed intervertebral disc. Special tests are routinely and frequently asked in the OSCE session, and also it is important in the long and short cases, and of course it will be asked somewhere in the MEQ and MCQ as well. When we examine physically, we'll see the muscle spasm. It is in the paraspinal muscles. Swelling is to be seen in the collapses, usually paraspinal area. Deformity could be in the form of scoliosis, thoracic kyphosis, or loss of lumbar lordosis, and sciatic scoliosis. Skin for the scar and sinuses. Telltale sign, efflate spots or hair tufts. Hair tufts usually can indicate a spina bifida occulta. The muscles for spasm, rigid paraspinal muscles, and can be atrophy or wasting as well. And gait will be used to avoid jarring of the spine. So it will be the short and wide. The limb length discrepancy sometimes can cause a problem in the spine, and so it should be taken into account. This is the gibbous in the spine. The temperature is taken. Tenderness is looked as the pressure over the spinous process or the paraspinal muscles. Muscle spasm is confirmed. It feels like firm, knotted. And the swelling is to be confirmed. Deformity is to be confirmed. There is a step sign that indicates the spondylolisthesis, and limb length discrepancy is to be confirmed. Remember that tenderness in the costovertebral angle signifies a renal infection. It is not a spine problem. The percussion in the spine, percussion is almost not done in the orthopedics, but here it can be done. Percuss the spine for tenderness by thumping, not too roughly, with the ulnar surface of the fist. And classically, percussion should trigger pain in the patients with vertebral malignancy or spinal infection. In contrast, percussion should not exacerbate discogenic pain. The movements, flexion, extension, lateral flexion, rotation, sober test is to be done. Neurological examination is to be done in a proper manner. The motor power test, sensory and reflexes, psoas L2, quadriceps L3, tibialis anterior L4, like that. Biceps C6, triceps C7, knees L4, ankle S1. Provocative test is done, and the most common ones are SLR test, contralateral SLR test, Lassegus sign, bowstring sign, and femoral nerve stretch test. SLR test.
What you do is catch hold of the leg around the ankle and raise it, keeping an eye over the face of the patient, and keep this straight. Knee should be straight, and pain should come in the range of 0 to 60 degrees. That means that there is a compression of the lower roots or lower lumbar roots has been impinged or under pressure.
When you raise a straight leg, knee extended, you are flexing the hip, pain should come in the range of 0 to 60 degree. If it comes, the SLR test or straight leg raise test is positive. It means there is compression of the nerve root. Now the Lassegus test.
Lassegus test. Repeat SLR. So again, suppose it is coming at 60 degree. Lower it 10 degree. And then supporting the limb in your other hand, sharply dorsiflex it, keeping an eye on the patient face. See for the grimacing of the pain. This is SLR test. What I am doing is, I have lowered so pain goes off. But by dorsiflexion the ankle, the sciatic nerve is still stretched, and then the pain will recur. So this is the Lassegus test.
We presume that the pain comes at 60 degree, lower it down 10 degree, and sharply dorsiflex the ankle. Again, the pain will be reproduced. Bowstring test, supposing the pain comes at 60 degree, bend the knee and press over the popliteal fossa. Again, you are irritating the divisions of the sciatic nerve, which is tibial nerve, and then
the pain will recur.
there is a Fallon test for the lumbar canal stenosis. This test attempts to reproduce the symptoms of the leg pain, weakness or numbness by causing neural ischemia. With the patient upright, ask the patient to bend into extension for a full 1 minute. This will accentuate the spinal stenosis. Then there will be a crescendo of leg symptoms followed by rapid relief when the patient flexes forward, usually places his hands on the examination table and places one foot on the stool as well. So this is the Fallon test. Imaging is done. So radiograph, simple plain radiograph is usually the first investigation that is asked for, and it is asked for when the pain is lasting for more than a month and it is not responding with the non-operative management. The MRI is usually the modality of the choice for the disc herniation. Bone scan is usually done to rule out the infection and occult metastasis. They also can cause pain in the back. The discography sometimes is helpful in determining the levels of the fusion that the surgeon has to do. And sometimes CT myelogram is needed. Simple radiographs, if done, the findings usually are the loss of lordosis. It usually denotes that there is a muscle spasm, there is a loss of disc height, and maybe in the old age, you will find the lumbar spondylosis or degenerative changes. The MRI has got advantages that it is very sensitive and it is highly specific. But there is one disadvantage that it shows a very high rate of abnormal findings in the normal population. The indications for obtaining an MRI is when the pain is lasting for more than a month and it does not respond to non-operative management, or else there are red flag signs such as infection, tumor, trauma, or caudai equina syndrome. So this is the finding of the MRI that you will be getting, and you can see here indentation of the cord, and the same here we'll be seeing indentation of the cord. How to visualize MRI on the transverse cuts? This is the T2 weighted axial image, and the cut is made from the L5 disc. This is the disc. And then we can see the thecal sac. It is filled with the cerebrospinal fluid that is whitish. And it also shows at the level of, see my cursor, at the level of 10 o'clock and 2 o'clock, the S1 nerve root is traversing. This is S1 nerve roots. And if there is a pressure, the disc material will come and press it. This is how we visualize the MRI in the transverse cuts. Sometimes myelography is needed, especially in those patients who have got metal implants. One indication is for the pacemakers patient as well. So this is how we see the abnormal findings in normal population. The incidence of the disc degeneration is so high and disc bulge so high. 20 to 40, it is 56%. And see, if you get the MRI done somewhere above the 60 years of age, the abnormal finding of the disc bulge will be 80%. That may not be pathognomonic of the prolapse intervertebral disc. The treatment could be non-operative in the beginning. The treatment should be non-operative in the beginning, and out of the non-operative, it is rest and physical therapy with anti-inflammatory medications. This is the first line of the treatment, and we must realize that 90% of the patients, they improve without surgery. So the bed rest is usually followed by progressive activity as the patient can tolerate the pain. The medications usually NSAIDs along with muscle relaxants if there is a muscle spasm, and there can be physical therapy added, especially the extension exercises are extremely beneficial for the patient. There can be selective nerve root steroid injection to relieve the pain. This is the second line of the treatment if the therapy and the medications are not working as desired. It's to be given as epidural or selective nerve block, and it leads to long-lasting improvement in more than 50% of the cases. Comparative results of the conservative and the surgical treatment, let us re-examine it. The patients operated on for proven disc herniation improved more rapidly than the patients treated non-operatively, because the causative disc has been removed and there is immediate relief. But after 4 to 5 years, both operative and non-operative treatment, they generally have comparable neurological recovery, and hence long-term results are similar with or without surgery. What is the operative treatment that we can suggest? Is laminectomy and discectomy. So discectomy is to be done at all costs. Disc which is compressing over the cord or the root has to be removed either by laminectomy or by laminotomy. Indications could be persistent disabling pain lasting more than 6 weeks that have failed non-operative options, including epidural injections. The progressive and significant weakness, if found in one or both limbs, this is an indication for the surgical intervention, as well as cauda equina syndrome, which requires urgent surgery. The positive predictors for the good outcome with surgery are when the leg pain is a chief complaint, when the straight leg raise test is positive, and when the weakness correlates with the nerve root impingement seen on MRI. What is discotomy and discectomy? Discotomy means incising the disc annulus, and discectomy means the removal of extruded disc material. And this can be performed via standard open incision or utilizing minimally invasive surgical techniques. And if required, this may be combined with an anterior column fusion, which is insertion of a cage filled with bone graft into the disc space so that the vertebral body fusion occurs. Now, many of the surgeons are of the view that disc arthroplasty should be included in the management of lumbar degenerative disc disease. And a number of cohort trials are showing the promising midterm results. But the financial cost of the implant does not permit it as a common surgical procedure after the discectomy has been done. Stem cell therapy can be instituted in some of the cases, but it needs further research to make it as a commonplace treatment. treatment. When the anterior column fusion cage is inserted, it increases the intervertebral gap and thereby indirectly decompressing the neural foramina. And then it relieves the foraminal sources of the neural compression. The complications of the surgery can be dural tear, it is 1% in the surgical procedures. There can be a recurrent prolapse. There can be infection to the disc, that is called discitis, and rarely vascular catastrophe caused by breaking through anterior annulus and injuring either the vena cava or the aorta. Thank you very much. Thank you.